This video presents the anatomy of the pharynx. Colloquially, you know the pharynx as the throat. However, as you visualize the throat through the oral cavity, you are only seeing one of the three regions of the pharynx called the oral pharynx, shaded here in yellow. The region of the pharynx, which lies above the soft palate and behind the nasal cavity, is the nasopharynx, shaded here in green. The third region of the pharynx is called the laryngopharynx, shaded here in blue. As its name suggests, this is the area of the throat that leads to the esophagus just behind the larynx, which is the voice box. The pharynx is the posterior region of communication between the nasal cavity, oral cavity, and the larynx. In the upper left image, you can appreciate that the nasal cavity is separated from the oral cavity below by both the hard palate, encircled here, and the soft palate. Air that enters into the nasal cavity flows into the nasal pharynx through the nasal choanae, which are the openings at the posterior aspect of the nasal cavities. Here's one nasal choana, and here's the other. The arched openings leading from the oral cavity into the oral pharynx are called the fauces, shown here. Lastly, air enters into the larynx by route of the laryngeal inlet, shown here. This schematic demonstrates the swallowing process. As a bolus of food or fluids move toward the esophagus, it is important to close off the nasal pharynx so that contents within the oral cavity do not inadvertently move upward into the nasal cavities. To protect the nasal cavities, the soft palate, including the uvula, shown here, elevates upward, sealing off the nasal pharynx. It also helps to direct food and liquids toward the esophagus. There is also a second flap called the epiglottis, shown here. The epiglottis acts as a shield, directing food and liquids away from the laryngeal inlet. To reinstate airflow, the soft palate returns to its resting position, and the epiglottis springs forward to allow air through the laryngeal inlet, as shown here in image 3. Simultaneously, the upper esophageal sphincter helps to prevent air from entering into the alimentary canal. In total, there are 6 muscles that act to constrict and elevate the walls of the pharynx, which is important for normal swallowing and speaking. 3 additional muscles enable the movements of the soft palate. We'll begin with the 3 pharyngeal constrictor muscles. All 3 pharyngeal constrictor muscles are innervated by the pharyngeal branches of the vagus nerve, cranial nerve number 10. Also notice that all 3 left and right pharyngeal constrictor muscles converge in the midline at an area known as the pharyngeal raphe, shown here. During dissection, in order to peer into the pharynx, you will use scissors to cut through the pharyngeal raphe. You will then reflect the pharyngeal constrictor muscles laterally. Recognize that there is overlap between the 3 pharyngeal constrictors in much the same way that stacked flower pots are seated within one another. This allows for contraction to occur sequentially from superior to inferior, thereby propelling food into the esophagus. Now let's look at the specifics of each pharyngeal constrictor. The superior pharyngeal constrictor muscle, shown here by the X's, is suspended from a bump on the base of the skull called the pharyngeal tubercle, shown here, which is associated with the occipital bone. From the pharyngeal tubercle, the left and right pharyngeal constrictor muscles extend forward toward the face to abut the buccinator muscle at the pterygomandibular raphe, shown here. Both the pterygomandibular raphe and the pharyngeal raphe are areas of connective tissue that adjoin 2 muscles. The middle pharyngeal constrictor muscle, shown here by the X's, attaches from the midline pharyngeal raphe to the hyoid bone and the stylohyoid ligament. Here is the side profile of the middle constrictor. Notice how it attaches to the greater horn of the hyoid bone as well as to the stylohyoid ligament. And here's the greater horn of the hyoid bone from the posterior perspective. In lab, in order to distinguish the superior from the middle pharyngeal constrictor muscle, you will look for the stylopharyngeus muscle, shown here. This muscle slips between the superior and middle constrictors. As we'll discuss more in a moment, the stylopharyngeus muscle is one of the elevators of the pharynx. The third and largest of the constrictors is the inferior pharyngeal constrictor muscle, shown by the X's. This muscle extends from the midline pharyngeal raphe and attaches to the oblique line of the thyroid cartilage, shown here. It also attaches to a small portion of the smaller cricoid cartilage below. Technically speaking, the inferior pharyngeal constrictor muscle is subdivided into a thyropharyngeus muscle and a cricopharyngeus muscle. Here's the thyropharyngeus muscle versus the cricopharyngeus. Another name for the cricopharyngeus muscle is the upper esophageal sphincter. For our purposes, you will not be held responsible for these distinctions. Saying inferior pharyngeal constrictor muscle is good enough. Do note, however, from a clinical perspective, the pharyngeal and esophageal mucosa can herniate between these two muscles in a condition referred to as a pharyngeal diverticulum, also known as Zinker's diverticulum. Patients with a pharyngeal diverticulum often have foul-smelling breath because food contents become trapped within the outpocketing shown here. These patients typically experience the sensation of a lump or foreign body in their throat, and they can also have dysphagia with regurgitation. If the diverticulum is large enough, it may also obstruct the esophagus, as shown here. The three pharyngeal elevators are not as broad or robust as the pharyngeal constrictors. Functionally, these muscles elevate the pharynx during swallowing and speaking. The stylopharyngeus muscle was mentioned previously as having a unique relationship with the superior and middle pharyngeal constrictors. Recall that the stylopharyngeus muscle, as shown here, slips between the superior and middle constrictor muscles. More specifically, the stylopharyngeus muscle attaches from the styloid process, shown here, and its fibers blend inferiorly with those of the walls of the pharynx. Unlike the other pharyngeal muscles, which are innervated by pharyngeal branches of cranial nerve 10, the vagus nerve, the stylopharyngeus muscle is innervated by the glossopharyngeal nerve, cranial nerve number 9. Notice how this nerve descends and spirals around the base of the stylopharyngeus muscle on its course toward the posterior tongue. This key nerve-muscle relationship is one that you will identify in the lab. From this internal perspective of the oropharynx, you can now view the palatopharyngeus muscle, shown here. This muscle originates from the hard and soft palate, and its fibers insert mostly into the lateral wall of the pharynx, with some fibers attaching to the thyroid cartilage. When peering into the oral cavity, at the back of the cavity are two arches. Here's one arch, and here's the second. The more anterior of the two arches is called the palatoglossal fold, or arch, shown here. And the more posteriorly positioned arch represents the palatopharyngeal arch, or fold. This latter fold contains the palatopharyngeus muscle, which you just visualized in the left-hand image. During dissection, once you strip away the oral and pharyngeal mucosa, you'll be able to visualize these delicate muscle fibers lying beneath. Situated between these two arches are the palatine tonsils, shown here. Notice again in this left-hand image, the palatine tonsil is reflected superiorly. It sits between the palatoglossus muscle, which underlies the palatoglossal fold, which is the first or anterior-most facing arch. It is also positioned in front of the palatopharyngeus muscle, which underlies the palatopharyngeal fold, in other words, the posterior arch. We'll discuss the location of additional tonsils momentarily. The third pharyngeal elevator is the salpingopharyngeus muscle. The prefix salpingo essentially refers to a trumpet-like tube. In this case, it's referring to the pharyngeal tympanic tube, also known as the auditory tube, aka the eustachian tube. The pharyngeal tympanic tube connects the middle ear cavity, shown here, to the nasopharynx, shown here. This tube is necessary in order to equilibrate the pressures between the external and middle ear cavities. At the entrance of the auditory tube within the nasopharynx, there is a mound of cartilage called the torus tubarius, shown here. When literally translated, it means the bulb or swelling of the tube. The salpingopharyngeus muscle therefore attaches superiorly to the tubal swelling called the torus tubarius, and its fibers blend inferiorly with the lateral walls of the pharynx. From this image, you can visualize the salpingopharyngeal fold shown here, under which lies the salpingopharyngeus muscle. Recall that these folds are nothing more than mucosa overlying the muscles. Contraction of the salpingopharyngeus muscle therefore elevates the pharynx, and it can also open the pharyngotympanic tube to help equilibrate the pressures between the external ear cavity and the middle ear cavity. The last three muscles to discuss are those associated with the soft palate. The levator veli palatini muscle pulls upward on the soft palate during swallowing and yawning to help close the nasopharynx from the oropharynx. From this posterior perspective, here you are visualizing the levator veli palatini muscle. The action of this muscle is captured in its name. Levator means to elevate, and veli palatini refers to soft palate. The levator veli palatini muscle is innervated by the vagus nerve. Simply remember that the term levator veli palatini has two V's in it. V stands for the Roman numeral 5. Since this term has two V's, that means it has two 5s, and 5 plus 5 equals 10. Therefore, cranial nerve number 10 innervates this muscle, the vagus nerve. The tensor veli palatini muscle has only one V in its name, which will help you to remember it is innervated by cranial nerve 5, specifically the mandibular division, V3. Suffice it to say, it is common practice to test students on the innervations and embryologic origins of these muscles. As its name suggests, the tensor veli palatini, shown here, is responsible for tensing the soft palate. This muscle will pull the edges of the soft palate toward the lateral pharyngeal wall, thereby helping to create a better seal between the nasopharynx and the oropharynx. An interesting feature of this muscle is that it uses the pterygoid hamulus, shown here, which is the hook of the medial pterygoid plate, as a pulley to redirect the pull of the tendon so that it will widen rather than elevate the soft palate. From a dissection perspective, you will not visualize either of these muscles, the levator or tensor veli palatini, until we dissect and chip through the lateral walls of the nasal cavities. The least impressive of these soft palate muscles, which is code for least important, is the muscularis uvulae, shown here. This small muscle will assist in elevating and retracting the soft palate. Like the levator veli palatini, it too is innervated by cranial nerve number 10, the vagus nerve. This slide is intended to recap much of the same information covered previously from a slightly different perspective. To see the soft palate in action, pause the video and open this YouTube link. From this posterior view, the pharyngeal wall has been opened, allowing us to visualize the piriform recesses, shown here. These recesses act as gutters to divert food and liquids around the laryngeal inlet so that ingested contents can enter into the esophagus instead of the airway. Spanning between the posterior tongue and the epiglottis, there are two lateral glossoepiglottic folds and a single median glossoepiglottic fold. Here's an example of a lateral glossoepiglottic fold, and here's the midline median glossoepiglottic fold. Between these folds are two depressions called valleculae. This is a clinically relevant landmark because the tips of curved intubation blades are placed in these valleculae in order to prevent the epiglottis from closing over top of the laryngeal inlet when placing an intubation tube to help a patient breathe. This small depression represents one of the vallecula. There are three sets of tonsils. A tonsil is a mass of lymphoid tissue. The pharyngeal tonsils, shown here, are embedded in the mucosa of the posterior wall of the nasal pharynx. Notice how they are located just above the torus tubarius, shown here. Enlarged pharyngeal tonsils are called adenoids. If they are large enough, they could cause respiratory obstruction. Within the oral pharynx are the palatoglossal and palatopharyngeal arches. The tonsillar fossa located between these two arches houses the palatine tonsil, shown here. The palatine tonsils are often referred to just as tonsils. Palatine tonsils tend to be larger in children until involution begins at puberty. Enlargement of these tonsils can also cause respiratory obstruction and dysphagia. In the bottom left image, notice how we have enlargement of the palatine tonsils. A tonsillectomy is the surgical removal of the tonsils. And lastly, the lingual tonsils are small tonsils located on the posterior aspect of the surface of the tongue, near the valleculae. From this side profile, you can appreciate the depression called the vallecula. Now let's look at the vascular supply of the pharynx. The main vessel supplying the pharyngeal wall is the ascending pharyngeal artery, shown here. This artery is a branch of the external carotid artery. The pedicle of the ascending pharyngeal artery originates on the medial side of the external carotid artery near the level of the lingual and facial arteries. In the right-hand image, we're seeing the medial surface of the external carotid artery. As such, we can now visualize the origin of the ascending pharyngeal artery. Here in this illustration, its branches are supplying the palatopharyngeus muscle. The other arteries listed on this slide have smaller pharyngeal contributions. For our purposes, we'll consider the ascending pharyngeal artery to be the most important. And here is the venous drainage of the pharynx. The upper pharyngeal muscles drain to the internal jugular vein by route of the pterygoid venous plexus, which is located within the infratemporal fossa. The lower pharyngeal muscles drain to the internal jugular vein by route of the pharyngeal venous plexus, shown here. Ultimately, blood supplying the pharynx is returned to the internal jugular vein. As you now know, there are two cranial nerves that supply the muscles of the pharynx. Cranial nerve number 10, the vagus nerve, and the glossopharyngeal nerve, cranial nerve number 9. Well, both of these nerves also happen to be involved in the gag reflex. Specifically, the afferent limb of the gag reflex occurs by route of the glossopharyngeal nerve. When the mucosa of either the oropharynx or laryngopharynx is stimulated, it will convey that sensation back through the glossopharyngeal nerve. In response to that stimulation, the efferent limb of the gag reflex sends out motor information by route of the vagus nerve, cranial nerve number 10. That motor information stimulates contraction of these muscles, so that you get elevation of the pharynx as a part of the gag reflex. From a clinical perspective, you want to remember that when you stick a tongue depressor in a patient's mouth, you always want to stay in front of the palatoglossal arch. That's because behind the palatoglossal arch, which is that front arch, is where the glossopharyngeal nerve will innervate the mucosa. So if the tongue depressor reaches beyond the palatoglossal arch, you'll stimulate the gag reflex. This slide summarizes key structures that you'll work to find during lab. After clearing away the buccopharyngeal fascia and the pharyngeal venous plexus, you will be able to identify the three pharyngeal constrictor muscles: the superior, the middle, and the inferior. And don't forget, slipping between the superior and middle pharyngeal constrictor muscles laterally, you'll find the stylopharyngeus muscle, shown here. And accompanying the stylopharyngeus muscle will be cranial nerve number 9, the glossopharyngeal nerve. As you work medially to dissect the nerves apart from the arteries, you will reveal the sympathetic trunk and the very large superior cervical ganglion. Here's the superior cervical ganglion. And extending superiorly from this ganglion is a nerve referred to as the internal carotid nerve. Once that nerve jumps onto the internal carotid artery, it forms the internal carotid nerve plexus. This is how sympathetic fibers get onto the internal carotid artery. From this perspective of the posterior pharynx, you will also work to identify other cranial nerves, including the vagus nerve, cranial nerve number 10, cranial nerve number 11, the spinal accessory nerve, and cranial nerve number 12, the hypoglossal nerve. And if you're really careful, behind some of these nerves, you might be able to find the ascending pharyngeal artery. Do recognize this artery is relatively small. Towards the end of your dissection, you will make a midline cut through the pharyngeal raphe. You will retract those muscles laterally in order to reveal the internal contents of the pharynx. From an internal perspective, you'll be on the lookout for the palatopharyngeal fold and the underlying palatopharyngeus muscle. You'll also search for the torus tubarius, and from there you'll see extending from it inferiorly the salpingopharyngeal fold, and underlying it will be the salpingopharyngeus muscle. Unfortunately, the salpingopharyngeal fold is not visible on this particular image. Internally, you will also be able to appreciate the choanae, which are the posterior openings of the nasal cavities leading into the nasal pharynx. You'll also see the fauces, which are the posterior openings of the oral pharynx leading into the oral cavity. You'll also visualize the epiglottis, shown here, and you should be able to see those depressions called the valleculae, indicated by the X. Recall that each valleculae had on either side of it either the median glossoepiglottic fold or the lateral glossoepiglottic fold. We will revisit some of these structures again when we discuss the oral cavity. This concludes the presentation on the pharynx. Until next time, happy studying!